Usually when we talk about a medical diagnosis, there's this expectation of absolute precision.
Oh, absolutely. Like it's engineering or something.
Right. It's supposed to feel like engineering. Like you break your arm, the X-ray shows a jagged white line, and the doctor points to it.
Broken or not broken. Very clean.
Exactly. It's clean, it's visible, and frankly, I mean, it's comforting to you as the patient.
We really crave that binary categorization in medicine, you know? We want the body to just be a machine with clearly labeled parts.
But the moment you look past that X-ray and step into the actual language of medicine, the terminology used to build those diagnoses well, that illusion of a perfectly engineered machine kind of shatters.
It really does. It gets messy fast.
So messy. We are diving into a linguistic landscape today that is, honestly, incredibly murky. And our mission for today's deep dive is to unpack this really fascinating linguistic paper on medical terminology that wades right into those muddy waters.
It's a great paper.
It really is. We're zeroing in on just 3 tiny prefixes today: dia, trans, and per.
Just 3 little prefixes, but they carry an enormous amount of historical and clinical weight.
And the core mystery this paper presents is just wild to me. If you look these 3 prefixes up in a medical dictionary, they have the exact same job on paper. They're all used to describe movement through or across something.
Right, passage and penetration.
Exactly. But in practice, out there on the hospital floor, they are absolutely not interchangeable.
Far from it, yeah.
I was trying to think of how to explain this, and the best way to visualize what we're dealing with is to imagine having 3 different keys on your keychain.
Okay, I like this.
So theoretically, all 3 keys are designed to open the exact same door, but you can't just grab any key. You have to use like one specific key if it's raining, a completely different key if it's after midnight, and the third key depends entirely on who built the door in the first place.
That analogy actually hits the mark perfectly. What's fascinating here is how this paper dismantles the layperson's view of medical language.
Because we assume it's perfect.
Right, we assume this terminology is a flawless, mathematically logical system. But exploring these 3 specific prefixes shows us that medical language is actually deeply rooted in, well, historical quirks.
Which is kind of terrifying, but also amazing. So to understand why we have 3 different keys for the same door, we have to look at the linguistic roots.
The origins.
We're looking at a collision between 2 dead languages here, Greek and Latin. Let's unpack the first contender, which comes to us from ancient Greek, the prefix dia, D-I-A.
A classic.
Right. And according to the source, dia means through, across, between, or thoroughly, completely.
It's a remarkably versatile word in Greek.
Then we have our 2 Latin contenders in the ring. First is trans, meaning across, beyond, or on the other side of.
Right.
And then its Latin cousin, per, P-E-R, which translates to through, throughout, by means of, or as an intensifier, it means thoroughly.
Exactly.
Now, looking at these definitions, I have to push back on the medical establishment a bit here.
Oh, let's hear it.
I mean, if they essentially mean the exact same thing across 2 dead languages, through, across, thoroughly, why doesn't modern medicine just, standardize?
Just pick one.
Yeah. Why not declare a winner? Say, okay, we're doing everything in Latin now and save every exhausted medical student on earth a massive headache.
Well, the urge to streamline is completely natural. But what's fascinating here is that the paper argues these overlapping definitions are precisely what make them so uniquely useful to a clinician.
Useful how, though? They mean the same thing.
Well, they aren't perfectly synonymous. From a distance, yeah, they look like identical keys, but up close, the teeth are cut differently.
Oh, I see.
Each prefix carries its own distinct shade of meaning that doctors rely on, even if they aren't, consciously thinking about ancient Rome when they write a prescription.
Okay, if we're claiming these prefixes have unique shades of meaning, I want to put that to the test. Let's look at the concrete examples for the source text and see how they actually behave in the wild.
Let's do it.
I want to start with the Greek prefix, dia. The paper lists a fascinating lineup of words where this shows up. We've got diagnosis, diarrhea, diaphragm, dialysis, diameter, and diabetes.
A very common lineup.
Right, but let's actually break these down. Because on the surface, a word like diabetes doesn't instantly scream through or across to me.
And that's where the etymology delivers a real light bulb moment. The paper points out that dia is used much more abstractly than the Latin prefixes.
Abstractly, how so?
It usually represents through in the sense of throughout a process over time, rather than literally poking a physical hole in a solid object.
Okay.
Take diabetes. The moot comes from dia, meaning through, and bane, meaning to go or to pass.
So to pass through.
Yes. You have to remember, ancient physicians didn't know about insulin or blood sugar. What they observed was a patient drinking massive amounts of water and, well, urinating constantly.
Oh, wow. So they just saw the mechanics of it.
Exactly. To them, the fluid was simply passing straight through the body like a siphon. So diabetes literally means a siphon, or something that passes fluid through.
That is incredible. They named the disease after the mechanical process they could see with their own eyes.
Right. It's not a physical barrier being broken. It's a continuous process occurring.
And you see that same continuous abstract process in the other examples too, like take diarrhea. Dia means through, and rain means to flow.
To flow through.
Yeah, that one is almost too literal. But I see the pattern. It's describing an ongoing action.
Yes, very continuous.
But what about diagnosis? How is that a process of going through?
Well, gnosis means knowledge. So when a doctor makes a diagnosis, they are moving through a cognitive journey of information.
A cognitive journey.
Yeah, they are filtering symptoms, ruling things out, and arriving at an understanding. It's not a needle piercing a membrane, it's a journey of deduction.
A journey of information.
Yeah.
That makes perfect sense. Even with dialysis, you're loosening or separating toxins through a continuous filtering process.
Exactly.
And a diaphragm is this muscular fence stretching across or between the chest and the abdomen. So dia is the conceptual, the continuous, the abstract process.
It handles the abstract beautifully. But, what happens when a surgeon isn't dealing with an abstract cognitive process?
Right, they need to actually cut into something.
Exactly. What happens when they literally need to cross a physical, biological barrier? That's where the Latin prefixes take over.
Okay, looking at the source's next group of words under the Latin trans, I think I see the shift here.
What do you see?
Well, the examples are transdermal, transfusion, transplant, transurethral, and even a non-medical word, transaction.
Right.
It clicked for me that neither of these, well, none of these are abstract like the Greek words. They all seem to involve moving a physical thing from point A to point B. Is that the distinguishing factor?
You've spotted the exact mechanism. The paper highlights that trans specifically focuses on the route or direction of movement across a barrier.
The route.
Yeah, it is the ultimate barrier crosser.
So a transplant is taking an organ and physically moving it across the barrier of one body into another.
Exactly. And a transfusion is taking blood and routing it across the barrier of an IV line into the circulatory system.
And transurethral is a surgical route going across or through the urethra to reach something else, like the prostate.
Right. It's purely directional.
Even transaction fits perfectly. You are moving funds or goods across the barrier of ownership, just point A to point B.
The prefix trans doesn't care about the complex process of getting there. It simply announces that a boundary was successfully navigated.
Okay, which leaves us with the final Latin prefix, per. The paper gives us percutaneous, perforation, permeable, and perfusion.
The P words.
Right. So if trans is the route across the barrier, what exactly is per doing?
Well, per is all about how you cross that barrier. The text clarifies that per usually describes the means or instrument of penetration.
The instrument?
Yeah. It's the physical act of getting through, often going by way of something else.
So like an instrument making a hole.
Think of the word perforation. When you perforate paper, or say a surgeon repairs a perforated bowel, something physical and often aggressive has punctured it.
It's an active event.
Exactly. The prefix highlights the act of penetration. And the paper also notes that per can signal the thoroughness and completeness of an action, which ties back to its Latin root meaning thoroughly.
Let's apply that to the example of perfusion then.
Okay, so perfusion is the thorough delivery of fluid, usually blood, into a capillary bed.
Let's pause there for just a second. For anyone not, currently brushing up on their anatomy, a capillary bed is basically that vast microscopic network of tiny blood vessels woven into your tissue.
Right, they're everywhere. So perfusion isn't just about blood passing across a boundary, it's about blood thoroughly penetrating and saturating that entire microscopic network of tissue.
So it's a complete saturating action.
Yes. But in the context of passing through a solid barrier, per heavily emphasizes the physical means or instrument used to get through.
Okay, let's synthesize this, because this next part of the paper completely changed how I view medical jargon.
It's a great section.
So we have dia, the abstract process. We have trans, the route or direction across a barrier. And we have per, the specific instrument or thorough means of penetration.
Right.
On paper, that is a tight, logical framework.
It's remarkably elegant, honestly, until it collides with reality.
Yes. Because what happens when the barrier crosser, trans, and the instrument of penetration, per, arrive at the exact same physical location?
Things get complicated.
The paper uses the human skin as the perfect stress test for these prefixes.
It's the great clinical conundrum.
The author points out this massive inconsistency in everyday medicine. Why do doctors prescribe a transdermal patch, but they insert a percutaneous catheter?
Same barrier, different words.
Exactly. Why not a percutaneous patch and a transdermal catheter?
Oh.
Both deal with the exact same biological barrier, the skin.
It reveals that hyper-specific nuance we've been talking about.
Let's try to map this with an analogy, because I want to make sure the mechanics of this are crystal clear for you listening. Is this distinction like taking a ferry across a river versus taking a massive drill to tunnel through a mountain?
I love that. That is a much better way to conceptualize the difference than simply saying they both mean through. Let's apply your ferry and drill analogy to the medical tools.
Okay, so if you apply a nicotine patch or a pain patch to someone's arm, it just sits there on the surface. The medication passively crosses the barrier of the skin.
It's taking the ferry.
The ferry, right.
The focus is entirely on the route the medication is taking to get into the bloodstream. It navigates across the boundary. Therefore, transroute, transdermal.
But a catheter is entirely different. A catheter involves a physical needle mechanically punching a hole by way of the skin to access a vein.
That's the drill tunneling through the mountain.
Ah, okay.
It is the active instrument of penetration. The focus is on the physical, aggressive means of entering. Therefore, per instrument, percutaneous.
Wow. The outcome is identical. You got medicine past the barrier of the skin. But the language focuses on the nature of the journey.
Yes.
One emphasizes the passive route, the other emphasizes the aggressive instrument. That's actually a really beautiful distinction.
It is beautiful. But the paper delivers a pretty sobering punchline about how this actually plays out in modern medicine.
Ah, yes, the reality check. The author states that if you were to walk into an intensive care unit right now, find 10 veteran clinicians, and ask them to explain this exact rule, why it's transdermal but percutaneous, most of them will not mention routes, instruments, or Latin derivations.
Not at all.
They will just shrug and say, well, that's just what it's called.
That's just what it's called, the universal fallback for messy language.
Which is so funny. But if there is no crisp, universally understood logical rule that clinicians are actively aware of, it raises a huge question.
Who's in charge?
Right. Who is actually in charge of policing these medical terms? Who is the gatekeeper deciding what gets the trans key and what gets the per key when a new technology is invented?
Well, the paper introduces the people behind the curtain for this, the historical heavyweights of nomenclature,
The committees.
the International Anatomical Nomenclature Committees, and the document specifically focuses on the Terminologia Anatomica.
I mean, it sounds like a spell from Harry Potter. Terminologia Anatomica?
It really does, but it carries that kind of weight in the medical world. The Terminologia Anatomica is the international standard for human anatomic terminology, and the current foundational version was published in 1998.
1998. Think about that for a second. We had the internet, we were mapping the human genome, we had incredibly sophisticated understandings of linguistics and biology.
And this 1998 committee was formed to replace an older, even more rigid standard, the 1895 Basel Nomina Anatomica.
The irony here is just staggering to me. You have a modern committee in 1998. They have the opportunity to wipe the slate clean. They could have resolved this messy collision of Greek and Latin.
They absolutely could have.
They could have created a strict, unified, mathematically logical system for prefixes moving forward.
They could have finally engineered the perfect single key for the door.
But instead, the paper explicitly notes that they simply inherited the inconsistencies of the past.
They just accepted
They
it.
looked at the 1895 document, looked at the messy, overlapping shades of meaning, and essentially shrugged on an institutional level. They agreed, hey, that's just what it's called.
They codified the inconsistency, but, consider the alternative and why they might have passed the buck.
Let's push on that, actually. Why wouldn't they fix it if they had the chance?
Imagine the absolute chaos of trying to retrain every single doctor, nurse, and pharmacist on Earth in 1998.
It would be a nightmare.
Medical language isn't just descriptive, right? It's operational. If you suddenly change the prefix for a procedure, a tired resident working a 24-hour shift might misinterpret it.
Oh, wow. I didn't even think of that.
Yeah, you don't want someone confusing a passive route with a physical instrument when they are holding a scalpel or, programming an IV pump.
So the risk of lethal misunderstandings outweighed the desire for linguistic perfection. The historical messiness was literally safer than a new logical system.
Exactly. The committee recognized that medical terminology is a living human language, not a line of computer code. It carries the baggage of its history.
That completely shatters the illusion we talked about at the beginning of the deep dive. If you've ever looked at a prescription pad or listened to a surgeon explain a procedure, there is this cultural tendency to view their words as pure, flawless science.
We want the clean X-ray.
We do. But this exploration of just 3 tiny prefixes, dia, trans, per, psycho, proves that the language wrapping that science is deeply, beautifully flawed. It's a human convention layered over strict biology.
When you hear a complex medical term, you aren't just hearing a scientific descriptor. You are hearing the echoes of ancient Greek philosophers observing a siphon, Roman physicians defining physical routes, and 19th century bureaucrats arguing over Latin translations.
And all of that is surviving into modern hospitals today.
It's pretty wild.
It really is like an archaeological dig hidden inside every diagnosis. To tie this all together, we've covered incredible ground today. We started with the assumption that words meaning through should just be interchangeable.
But they aren't.
Not at all. By looking at the specific examples in the paper, we saw how Greek gave us dia for continuous abstract processes, like the cognitive journey of a diagnosis or the fluid mechanics of diabetes.
And Latin gave us transfer for the route across a barrier, like navigating the ferry of a transplant.
While also giving us perfical for the specific active instrument of penetration, like the aggressive drill of a percutaneous needle. We proved that while these prefixes might theoretically open the same door, how you go through makes all the difference in the world.
Even if the doctors using them just accept it as tradition.
Right. It's a tradition that works, despite its quirks.
Absolutely.
Which brings me to a final thought I want to leave you with today. We talked about how the 1998 committee simply accepted the inconsistencies of 1895 because changing them was just too dangerous. They inherited the linguistic accidents of the past.
Yeah, they played it safe.
But science is accelerating. I mean, we're inventing new microscopic procedures, discovering entirely new biological pathways, and crossing barriers the Greeks and Romans couldn't even fathom.
The terminology has to keep expanding to describe it all.
Right. So my question to you is this. Will there ever come a breaking point? Will there come a moment where medical terminology becomes so convoluted, so heavily weighed down by these historical inconsistencies that a future committee simply cannot afford to inherit it anymore?
It's a profound question. At what point does the historical keychain become too heavy to carry?
Exactly. When do we finally have to change the locks on the door entirely? Or are future generations of doctors centuries from now doomed to keep memorizing the linguistic arguments of ancient translators just to practice modern medicine? Thank you for diving into this with us. Keep questioning the words you hear, look for those hidden shades of meaning, and we will catch you in the next deep dive.